Okay, so I think we can start. Dear audience, welcome again. My name is Mariangela Pellegrini. I'm the European, I work for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease, and I'm the Educational and Patient Program Manager. So as you know, the program today is named Topic on Focus on Constitutional Thrombocytopenia. And it's an accredited European program that has been built in partnership with the French Reference Center for Inherited Platelet Disorder and the French Constitutional Bleeding Disorder Network. And indeed, the main objective of this program is to disseminate up-to-date knowledge in the field of constitutional thrombocytopenia. Before entering in today's lecture and providing you with the information on the expert speaker we can count on today, I would like to share with you some home rules. So as you can see, your microphone is muted and will be muted along all the presentation. If you want, during the presentation, you can write your question in the chat, or you can raise your hand and we will pass you the floor for sharing comment, feedback, or question, of course. So at the end of the presentation. And also, as you can see, this session is recorded because the video will implement the e-learning environment of the ERN, so the website, YouTube, and so on. So if you don't feel comfortable, you can change your name in the platform or switch off your camera or notify to me. And finally, this program is accredited with continuous medical education points of the European Body of Accreditation in Hematology. One session is 1 credit. You will receive an email from us explaining to you how to request credits at the end of the program. So you will know how accumulative session you have with instruction to technically get the credit. Also, forget the credit. At the end of this webinar, you are going to receive a satisfaction survey. It takes 1 minute to answer, but please answer to it. So, we can arrive at today's lecture, which is the first part of the topic, Inherited Thrombocytopenia Clinical Cases. With us, we have Professor Marie-Christine Alessi, who is professor in hematology at Aix-Marseille University in France. Since 2014, she has led the French Reference Center on Inherited Platelet Disorder, which is a medical network throughout France with the aim of improving patient care and reducing diagnostic impasses. So I'm very proud to pass the floor to her. So please, Professor Alessi, the floor is yours. Thank you very much.
So thank you, Maria Angela. So first, I would like to thank a lot EuroBloodNet for supporting this webinar session. And so hello, everyone. Today, we have planned to illustrate inherited thrombocytopenia through real-life clinical cases. And I have chosen to show you that inherited thrombocytopenia may be the gateway of more complex disease. So I will present to you 4 cases, and all these cases illustrate that thrombocytopenia may be the first sign of a more complex disease. So this is the first illustration. It is a family referred to our Center for Exploring Familial Thrombocytopenia. Both the mother and her child had moderate platelet count, as you can observe, and also a slightly increased platelet volume. The child experienced prolonged bleeding at cuts and was treated with tranexamic acid for tooth extraction and adenoidectomy, while the mother suffered menorrhagia. The child also suffered from gastroesophageal reflux and had difficulties regulating emotion and behavior. And as you can see, there is a misdiagnosis in the mother with a history of treatment with corticoid and immunoglobulin, and also history of miscarriage. So we sequence our gene panel, and a diagnosis of filaminopathy was established. The variation found is a very severe variation. It is a deletion, and this variation has already been reported in the literatures. So first, I would like to give you some information of the relation between filaminae and platelets. So if you look to the left on this slide, you can see that filaminae promotes high-angle branching of actin filaments, organizing a three-dimensional network, leading to the mechanical stability of the platelets. So this is a very important protein for platelet function. Filaminae is composed of an N-terminal actin binding domain that allows interaction with the cytoskeleton. This domain is followed by a 24 immunoglobulin-like repeat and a C-terminal domain that mediates dimerization. And interestingly, filaminae bind to GP1B and is involved in the regulation of downstream signaling and adhesion to von Willebrand factors under shear rate. And filaminae is also able to interact with GP2B3A, and it maintains integrin 2B3A in an inactive state, as you can observe here. And the activation of 2B3A requires disruption of the filaminae beta-3 link, and mishfilin competes with beta-3 for filamina binding, and this allows the association of beta-3 with taline and kinlin, and allow the activation of 2B3A. So it is also important to underline that filaminae interact with over 90 other proteins in platelets, such as RHO-A, strongly involved in platelet formation, such as STIM1, that is involved in calcium metabolism, such as SIC, that is involved in the response of platelets to collagen, and PAXIM2, that regulates membrane architectures. So let's talk about filaminae-related diseases. Filaminae is encoded by the X chromosome. This disease is severe in males, often leading to death, and unless there is mosaicism or hypomorphic variation. Thus, patients correspond mainly to women. And mutation in filaminae leads to two main diseases. The first one can be called filaminae deficiency syndrome. This disease is mainly due to loss of function mutation leading to truncated filaminae. And in this situation, missense variation are very rarely involved. So this disease is associated with thrombocytopenia, and there are other clinical signs. Filaminae is strongly involved in neuronal migration, and thus heterozygous loss of function variant lead to periventricular nodular heterotopia. And this manifests as a bilateral of unilateral nodules lining the margin of the cerebral ventricles. So PVNH, this neuronal disease, is associated with seizures. This syndrome also includes bowel, cardiovascular, joint and skin issues, as well as pulmonary issues. The second situation corresponds mainly to missense mutation, and this situation is known as the result of gain-of-function mutation. And this mutation leads mainly to skeletal dysplasia, leading to different syndromes such as the autopalatodigital syndrome, frontometaphyseal dysplasia, etc. But in this syndrome, in this situation, until proven otherwise, there is no clear association with thrombocytopenia. So what are the signs that may indicate Filial MHEMO-related thrombocytopenia? It is important to know that half of patients have seizures, but not all the patients. Half of the patients have aortic aneurysm. A third have a history of patent ductus arteriosus, and some have a history of atrial or ventricular septal defect. Very important is the fact that more than half of these patients exhibit joint hyperlaxity. So this sign is very important to look for. And more than a third have skin hyperelasticity. Emphysema is also present, but is probably underestimated. And an important element is that probably all, but most of these patients have pathognomonic cerebral MRI with these particular nodules lining ventricles. So what is the platelet phenotypes in a filaminopathy? First, thrombocytopenia. It is usually a moderate thrombocytopenia associated with enlarged platelets. Sometimes there is abnormal alpha granule distribution compared with control. There is also reduced aggregation in response to collagen. This is probably due to the binding of filamina to the sick, strongly involved in the response to collagen. And very importantly, there is a subset of platelets deficient in filaminase. This is a double staining of MYH9 in red and filamin A in green. And you see that all control platelets are double stained, while large patients' platelets are devoid of filamin. And last, but this is rarely performed, megakaryocytes generated ex vivo showed incomplete maturation with a reduction of platelet production. And this is associated with a dysregulation of Rho-A activation that is strongly involved in platelet formation. So interestingly, I would like to show you that it is quite easy to evaluate filamin A, the presence of filamin A in platelets using a flow cytometry. So this allows to quantify the percentage of platelets without filamin A. So as you can see, we have, I present here the result obtained in 2 patients with very severe variation. You can see that when you gated the population of CD41, there is clearly 2 populations. 60% of the platelets have filamin A, whereas around 30 to 35% of platelets are empty. And if you compare to control platelets, the normal value of empty platelets is less than 8%. So this is a quite easy method to evaluate the filamenate content of platelets. So we therefore went further to look for signs of filaminopathy in our family. MRI revealed PV and H in both the mother and the child. The mother is a nurse, and she described some neurological discomfort, but she has not a true diagnosis for this discomfort, and the neurologist identify and diagnose a partial epilepsy in this mother requiring treatment. And neuropsychological evaluation evidence also autobiographical memory disorders. She presents aortic insufficiency and joint hyperlaxity as her child. And we think that her recent miscarriage may have involved a male fetus. So this is very important to do this kind of diagnosis, because this family is now receiving care for neurological, vascular, and orthopedic issues, and will benefit from genetic counseling for future pregnancy. So what is also important to highlight is that most of the described variation associated with PV and H and probably thrombocytopenia result from severe genetic defect, and all the described mutations are indicated here on the top of this slide. And this leads mainly to a truncated protein. The majority of missense mutations are found in exon 2, which code for a domain highly involved in actin binding. So in red are the published variation associated with thrombocytopenia. And as you can observe, this corresponds mainly to a very severe variation. And in blue are the variation we have discovered in the French Reference Center. And in my center, we are very concerned when we detect missense variation. It is not very easy to assess the pathogenicity of any observed missense filamin variant. And so we have some difficulties when we have front a missense variation, because it's difficult to give appropriate counseling on disease risk. So this case illustrates the fact that first, thrombocytopenia could serve as a starting point to delve into a more complex disease, such as filaminopathy. And this case also underlines the fact that a moderate familial thrombocytopenia needs to be explored. So about filamina-related thrombocytopenia, there are, of course, several remaining questions. The first is to evaluate the prevalence of thrombocytopenia in patients with PV and H. This is unknown. A second question is, what is the specificity of platelet filamina deficiency? Because we need a large population to answer this question. That is to say, does thrombocytopenia exist without filamina deficiency? We could imagine qualitative defect without a true deficiency, and both these need to be collected. What is the specificity also of PV and H? As I said before, almost all of the patients have a PV and H. And if we look to the literatures, there is only one case with one filamina variant. It is a missense variant with intestinal malrotation, with thrombocytopenia, and without PVNH. So we need to better document the possibilities that PV and H could not be a very specific sign of this disease in case of thrombocytopenia. Okay, so the second case illustrates how familial thrombocytopenia can exceed the typical or classical framework of inherited thrombocytopenia. So this case involves two sisters from a consanguineous marriage. These sisters were explored at the age of 3 for fluctuating thrombocytopenia, but sometimes, as you can see here, very severe thrombocytopenia. And this thrombocytopenia was associated with spontaneous bleeding when the platelet count were very low. These two sisters have mental retardation. They have recurrent febrile episodes, cutaneous xerosis, that is to say, dry skin. They have also lymphopenia, and exploration evidence reduce lymphocyte proliferation in response to several inducers, PHA, candidine, etc. So the physician searched for metabolic diseases, this keratosis, and this was negative. And they searched for genomic imbalance using CGH array, but CGH array did not reveal any genomic imbalance. So we first sequence our gene panel specific for platelet disorders, specific for constitutional platelet disorders, and this sequencing did not reveal any mutation. So we performed exome sequencing, and exome sequencing unveiled an homozygous variation in TPP2 gene. So this variation is not present in public database. It appears damaging using all the software we use. And this homozygous mutation could fully explain the clinical phenotype in these two sisters. TPP2, to give you some information of this gene, encodes a ubiquitously expressed cytosolic protease involved in protein degradation that play a role in immune function. And a deficiency of TPP2 is thought to cause an imbalance in the cellular and lysosomal proteolytic pathways, allowing dominance of the lysosomal pathway. Lysosomes accumulate, reduce glycolysis, and impair both cellular metabolisms and the production of effector cytokine. This rare genetic immunological disease occurred in early childhood. It induced immunodeficiency associated with a recurrent infection, a severe autoimmune disease, and the thrombocytopenia described in these two sisters is mainly due to this autoimmune defect. So this disease is associated with mild to moderate developmental delay, and also lymphopenia and defect in lymphocyte proliferation. So I would like to show you these cases because it is really a borderline cases, but it is an inherited thrombocytopenia in some way. So the third cases illustrate again that inherited thrombocytopenia could be an entry for complex disease. So these cases correspond to a patient explored in Paris by Anne Vincenot. So this is a 48-year-old man. Platelet count was moderately decreased, and remarkably, 40% of platelets were very large, even giant, with some vacuoles. And thrombocytopenia was observed in one sister, so it is a true familial thrombocytopenia. And medical history indicated several coronary bypass surgery with hypercholesterolemia, treated with ezetimibe, with a family history of cardiovascular events. There is no consanguinity, and sequencing revealed an ABCG8 homozygous variation. So to remind you, the heterodimer of the ATP binding cassette ABC G5 and G8 is a major transporter of cytosterol. And this heterodimer promotes the secretion of cholesterol and xenosterol and cytosterol into the bile and the intestinal lumen, functioning as a reverse cytosterol cholesterol transport pathway. That is to say that this transporter is a means to prevent an excess of cytosterol in the circulation. And thus, in case of homozygous or double heterozygous mutation, phytosterol are maintained in the circulation and accumulate within the tissue, leading to xanthoma, premature atherosclerosis, stomatocytosis, and of course, microthrombocytopenia. But unfortunately, there are few early warning signs to diagnose and to evoke this etiology. First, increase in LDL cholesterol is not always present. So if present, a poor response to statin treatment could be an indication. Clinical signs are not always present at a young age, and it is very important in case of this mutation to perform the diagnosis as soon as possible to prevent the occurrence of complication. And cytosterolemia measurement is not easy to do and need to refer to specialized laboratories. So I have some recommendation for this disease. First, to do this diagnosis as early as possible, and sequencing is probably the good way to do. And of course, to as soon as possible apply treatment, and the treatment is based on the inhibition of cytosterol absorption using ezetimibe, and also diet recommendation. And for this patient, it is not possible to follow the Mediterranean diet. So the first cases, and it is the last cases, again illustrate this relation between thrombocytopenia and complex disease, but it is a very particular cases. So two brothers were addressed to our Center for Platelet Exploration due to cutaneous mucosal bleeding. So the entry in the disease was not thrombocytopenia, but bleeding. So these two brothers suffered hematoma, bruises, easy bleeding, nosebleed, and one of them received platelets before surgery and tooth extraction. So these two brothers have been explored on several occasions, and they exhibit exactly the same phenotype. So this is the result we obtained at the age of 80 months. As you can observe, there is the blood cell count was normal, the platelet count was normal, there is no defect in coagulation, but at this time we performed bleeding time and we observed an increase in bleeding time that was not corrected by DDAVP. And we observed a severe platelet aggregation defect in both brothers. So we obtained a quite nice level of platelets in the PRP, and we observed that collagen and arachidonic acid failed to induce platelet aggregation. Reduced aggregation was also observed in a response to ADP, and this was observed on several occasions in the absence of medication. And looking at this result, at the beginning, the diagnosis of Glanzmann thrombasthenia was proposed, but GP2B3A was nicely present at the cell surface of platelets. There is no genetic defect, and GP2B3A was activated by high concentration of TRAP6, so it was not a Glanzmann thrombasthenia. So we continue the exploration, and we found a strong decrease in the dense granule count. Here is the quantification of dense granule using fluorescence microscopy. So in the x-axis, you have the dense granule number, and is y-axis the percentage of platelet. The black corresponds to control and the red to patients. And you see that in the two brothers, there are a shift of the curve to the left and a great percentage of platelets without any granules. And this was confirmed using electronic microscopy that showed a severe dense granule deficiency with 65 to 80% empty platelets. And this was confirmed also with other methods. So very important is the fact that thrombocytopenia was identified as the disease progressed. At 5 years old, the platelet count for one child start to decrease with a number around platelet count around 194. And for the second child, the platelet count was 131. So you have here the curve observed during the life of these two children. Currently, the platelet count is between 50 and 100 giga per liter. And at the same time, red blood cells abnormality appeared. The two brothers displayed a progressive increase in MCV, mean corpuscular volumes, reaching more than 100 femtoliters. We observed schizocyte, a persistence of F hemoglobin, and this at the beginning induce a diagnosis of thalassemia. Numerous red blood cells have an heterogeneous distribution of F hemoglobin. So we apply our gene sequencing, and this sequencing reveals a GATA1 variation located in the second zinc finger domain. So to give you some information of GATA1, GATA1 is an essential transcription factor for erythrocyte and megakaryocyte differentiation. GATA1 binding motifs have been found in several important platelet molecules, such as GP1B, ETGR2B, GP9, PF4, MPL. So it is a transcription factors strongly involved in platelet function and platelet production. So GATA1 is located on the X chromosome, thus only males are affected. And the proteins contain two highly conserved zinc finger domain. And briefly, we could say that the C-terminal zinc finger binds with high affinity and specificity to DNA, while the N-terminal finger domain bind with great efficacy on FOG1 and enhanced stabilization of this binding. So several loss of function mutation have been described in patients, and most of these variations have been described in patient, and most of these variants affect the N-terminal zinc finger domain. But our case is very original and quite rare because it concerns the C-terminal zinc finger domain. And clearly, literatures and our own work indicates a genotype-phenotype relationship depending on the mutation site. It appears that mutation in residues that disrupt FOG1 GATA1 interaction lead to more severe disease that sometimes need a bone marrow transplantation. And you have here a description of the residue that are strongly involved in the interaction between GATA1 and FOG1. There is a residue 205, 208, 206, and in case of mutation in this residue, there is a profound anemia and a profound thrombocytopenia. But if the residue are not involved in this interaction, the disease severity is less. And as you can observe for our cases, there is no anemia. Of course, there are some signs indicating that there is some effect on erythropoiesis, but there is no anemia. And there is a strong defect in platelet function and a moderate thrombocytopenia. So to conclude, I would like today to give you some important message. First, exploring even mild familial thrombocytopenia can reveal underlying pathologies that require multidisciplinary management. This have been demonstrated for Filamina and for ABCG8. Second, gene supporting syndromic thrombocytopenia may be outside the classical list of known genes involved in inherited thrombocytopenia, and I think it is important to work with people involved in immune deficiency and in more systemic disease, because we have patients, several patients in this situation. It is also important to closely examine blood smears and hemocytometry results. And I have shown you that the demonstration of schizocyte, giant platelets with vacuoles and stomatocyte, as well as the look for mean corpuscular volume could give some indication. Interestingly, but it is really a specialized cases and very rare cases, but thrombocytopenia cannot be present in young children, and there is sometimes association between platelet dysfunction and thrombocytopenia, and this can evolve over time, and we have seen this kind of situation with GATA1. And in case of syndromic form, the severity of accompanying symptoms may be influenced by the mutation location and the affected functional domain. So there is no one gen, one disease. Sometimes there is one gen and several diseases. So, and thank you very much for your attention.
Thank you very much, Professor Alessi, for this comprehensive presentation. So we have already received the first question. I'm going to read it. Okay, so for case 3, does inhibition of cytosterol absorption by ezetimibe restore a normal platelet count?
For this case, I don't know. But we can imagine that if we decrease cytosterol accumulation in tissues and in red blood cell and in platelets, we can improve the platelet counts. But for this case, I don't know.
Thank you. So for the audience, now you can also unmute yourself if you prefer to take the floor rather than writing. So we can wait a few other minutes to see if other questions arrive. Also, you can also share comment or feedback. And also, as I always like to say, it could be also on the other way around, Professor Alessi, if you have any question from the audience, it could also go on the other direction.
So these cases were very specific. But I thought it was quite interesting to see a very rare condition and very borderline cases.
Indeed. And the high participation for this webinar really goes in this direction. So we have one feedback. Thanks for great presentation. Thank you.
Céline, thank you. So you know, you have the name of people involved in the platelet exploration in Marseille on the last slide. So there are two pediatricians, Paul Saultier and Céline Falaise, and we are two mainly biologists, myself and Manal Ibrahim, and so we are a small team, and we can help you if you have questions on platelet disorders. Okay.
Okay, so I think everything was very clear. Thank you again, Professor Alessi, for having shared your expertise with us. And I wish a nice evening to all the audience. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.